Thanks, Corinne. We'll give people just another minute or so to join, and then we'll go ahead and get started.
Yeah, all good. Are you available later today or? Yeah. I'm not actually doing that.
All right. I think it is 2 past on my end. We can go ahead and get started, and people can continue trickling in through the waiting room here. But hi, everyone. Thank you so much for joining our May Implementation Affinity Group meeting. My name is Demery Henderson. I'm the Grants and Programs Manager at Civitas Networks for Health. And if in case you didn't join us in February, I'll be facilitating the call today, and we're really happy that you all were able to join us. So before we go ahead and fully dive in, just wanted to go through an overview of our antitrust practices. So Gravity Project participants have the responsibility to fully comply with federal and state antitrust laws, and I won't read through all of it, but feel free to take a look. And this meeting is being recorded as well, and we'll post the slides on our Confluence page following the meeting. Yes, so housekeeping reminders, this meeting is being recorded, like I just mentioned, and the slides will be posted on the Affinity group page. But just a reminder to mute yourself when you're not actively talking, and then feel free to use the raise hand function on Zoom when you're wanting to chime in with something, and we will call on you. All right, so here's our agenda for today. So I will start with just a quick intro of how the meeting's going to go, and then we'll move into Gravity updates. And then we'll also be hearing from representatives at Unitas and Together Now about how Gravity referral standards are helping to decrease provider and patient burden. And then following the presentations, there'll be some Q&A. And then towards the latter part of our meeting, we will facilitate community office hours where you all can ask open questions, and then we will wrap up. Okay, so just quickly, I wanted to introduce myself again and then quickly orient everyone to the few changes if you weren't able to join us in February. So again, my name is Demery Henderson. I'm the Grants and Programs Manager at Civitas, and I've supported Gravity in various project management capacities for the past 4 or 5 years. But recently, I will be more formally supporting the Affinity Group presentations as part of the Gravity and Civitas partnership. So Civitas is a member and implementation partner of Gravity, and alongside the Gravity team, we will be facilitating the Affinity Group calls going forward. So as you can see from the visual here, the 2 different work streams of Gravity, and then this is kind of where Civitas's role is in the implementation part. So thanks so much again to the Gravity Project team for being great collaboration partners as always. And then if you're not familiar with Civitas already, we're a nonprofit mission and member-driven organization focused on improving health outcomes for all through health improvement and data exchange. So our membership is really diverse, includes HIEs, RICs, QIOs, and others taking data-informed multi-stakeholder approaches to health improvement. And so at Civitas, we like to think of ourselves as kind of the bridge between data and doing. So our members do incredible work, and then we help bring that work to the national stage through our program portfolio. So really grateful to all of our program partners, including the Gravity Project. So they are helping us with SDOH standards implementation efforts in New York, which is one of our programs. And again, thanks to all of our partners who help us bring the attention of the great work of our membership. So enough with me. I will turn it over to Corinne Bogan, who's the Gravity Project project manager, for some Gravity Project updates, and then we will turn it over to the Unitas team.
Yeah, great. Sounds great. Thanks, Demery. Probably won't need the full 10 minutes. I'm really excited to get into our topic today and kick it over to the Together Now and Unitas teams that are joining us here today, but wanted to use this opportunity to just orient everyone and give some brief high-level updates on the Gravity Project and what's been going on with Gravity as a project-wide since the last time we came together in February. So within the terminology work stream, Today is actually the last terminology community collaborative call before a scheduled 2-month build period. And so this meeting is directly following our meeting today. It begins at 4 o'clock until 5:30. This will be the consensus vote on the person level racism and ethnic discrimination domain, the toxic stress and protective factors domains. So if you have some time and want to join our terminology team, stick around after the implementation affinity group call. And we will reconvene community collaborative public calls August 7th at the end of the summer, kicking off our food access, neighborhood safety, and access to green space domains as well. So that's exciting. Exciting news on the technical work stream side. We continue to meet bi-weekly on Wednesdays, and we recently published our standard for trial use 2.3 implementation guide, supporting US core versions 3.1, 6.1, and 7.0, and then including a expanded SDOH code value set with domains for incarceration status and language access. I will actually include a link to that here in case anyone is very techy and wants to check it out. And we continue to meet bi-weekly again, like I said, on our public calls. And we're really working to engage more with our community as we enter into the build for STU 3.0. And so we have included the topics of our upcoming technical public calls on our upcoming meeting information page on Confluence, which I'll also link below here, so that our community knows how to better engage and who from their organization maybe to send to these calls, and just how to engage with Gravity as we build 3.0. So our next upcoming public call, June 11th, we will focus on the social care capacity use case. This will be the second time as a technical community that we've discussed this use case, and we'll look to bring some fire solution options to this call. And then we'll also use part of this call as a CMS July Connectathon kickoff as well. And if you're not aware, CMS and HL7 are holding a virtual Connectathon event this July, and registration is totally free. It's open now until June 30th. So I will include the link to the registration there as well. And Gravity, of course, will be having an SDOH track at this Connectathon, and we are always looking for testers at the Connectathon as well. So if you are interested in attending, either as just an observer or a Connectathon tester, please reach out. You can register directly at that link I just shared, and we'd be happy to engage with you on how we can utilize your organization to test our use cases. After the June 11th public call, we'll be diving into the self-referral use case. And this initial call is more of a general call for all audiences that may be familiar or utilize this self-referral type of use case. We'll be looking to define and just explore the implications of this use case in that first call. And then more generally, you can check out kind of external events that Gravity has a presence at on our Gravity calendar, which I'm sharing here as well. We have some exciting conferences that will be present at over the next couple of months and throughout the summer, and would love to just connect with anyone within our community in person or there if you'll also be at any of those that we have listed on our calendar. We update this pretty often. We try weekly, and so this is a good source of information for where to connect with Gravity in the field. And then further than that, just wanted to make sure that everyone here that's found their way here to this call is also on our Gravity listserv. And so I will include that link in the chat as well. And that will just ensure that you get all of the upcoming meeting information for both our technical terminology and then implementation affinity group calls as well. And so we want to make sure that our community is engaged and has all the most up-to-date information coming out of Gravity. And so if you're not already connected to our listserv, we ask that you subscribe. Great. And I know we'll have time at the end for kind of office hours and questions. So with that, I'll turn it back to Demry and the Unite Us and Together Now teams for their presentation today.
Awesome. Thanks, Corinne, and thanks for sharing all of that great info in the chat here. Definitely encourage everyone to check out those links. But now we will get into the meat and potatoes of our presentation and meeting here today. So I will turn it over first to the Unitas team. I believe we have Rachel and Emily both on, and they will be discussing how gravity referral standards are decreasing provider burden. And then after that, we'll have some Q&A. So if you want to chat in your questions during the presentation, that works. And then we can take some questions at the end from the Unitas team. So I will hand it over to Emily and Rachel.
Thanks, Demery, and thanks, Corinne. Hello, everyone. My name is Emily Anders. I'm the Director of Payment Strategy at Unitas. And like Demery mentioned, I'm going to talk to you all a little bit about how Unitas supports and leverages Gravity Project standards to be able to see that ROI and reduce provider burden. So I'm going to spend some time, hopefully like 45 seconds, just giving an intro to Unitas if you haven't heard of us before, but then get into more of the meat and potatoes, which is really how we look at ROI, specific examples of ROI that we've seen in generating that for reducing provider burden. And then I'm going to pass it over to Rachel, my colleague Rachel Eager, who's waving, who's going to talk more about the how. And that's where obviously the Gravity Project standards come into play and what we see as core kind of foundational components to be able to achieve that type of ROI. So with that, if we go to the next slide. Okay, again, no one time me, but I'm going to try to keep it really short. So Unitas at a really high level, we are a technology company. We drive the collaboration across sectors. You'll see here government, healthcare, social care represented to be able to identify, deliver, and pay for services that impact whole person health. So we do this through our suite of solutions on the right-hand side. So the ability to identify and predict needs, analyze the impact of interventions through our various data offerings, coordinate and track outcomes together. This is leveraging our closed loop referral platform that enables these different sectors to be able to send and receive secure referrals on behalf of their shared client members, patients, and then equally as important, be able to see the outcome on the other end of that referral. So whether or not that individual actually received access to care, what access did they get, what services did they get, and if they didn't, why? And then last but certainly not least, this is where I spend the bulk of my time at Unitas with our payments product, but really enabling government and healthcare sectors, so both payers, healthcare systems, to be able to easily, seamlessly invest in these non-medical or health-related social needs services for their individual clients, members, patients. And then on the flip side of that, making it really easy for community-based organizations to be able to invoice and be reimbursed for those services. So that's us at a high level. If we go to the next slide, I have one more overview slide. This is just high-level metrics of Unitas, so you can kind of get a sense for breadth and depth across the country. We were founded in 2013 by two veterans who were navigating their own transition from active duty into civilian life, back into civilian life, and found obviously a fragmented system when they were trying to get connected to services and getting their family set up. And wanted to solve that problem for other veterans navigating a similar transition. So they quickly learned that that is not a unique problem for the veteran community, but that's something that we see in communities, populations across the country. I don't think I need to convince anyone of that. I think that if you are here today, you definitely believe in that. And we're all trying to solve that fragmentation problem. So again, not going to go into any of these metrics here. So let's go to the next slide. Okay, so again, I'm gonna zoom out on ROI as a whole and how we kind of think about ROI at Unitas. And then I'm going to share some specific examples of evaluations that we've done with our own research and evaluation team in partnership with our customers, partners, other stakeholders to understand that ROI on reducing provider burden specifically. So first and foremost, I think ROI can really be an all-encompassing term, but there are a lot of different types of ROI. So we always want to work with our customers and our partners to understand specifically what in their programs they're looking to achieve so that then we can work backwards from there. I think ROI, oftentimes when we use it, it can be automatically associated with thinking about the total cost of care reduction, which is something that everyone should want to achieve, right? We know that not Unite Us, the United States has a healthcare spending problem. And we know that now that there's gaining momentum for addressing the non-medical drivers of health, the social drivers of health, that we want to be able to prove out that ROI, that investing in these types of services leads to that total cost of care reduction. And of course, that's something that we have helped our customers and partners prove out, but that's not really what we're talking about here today. And I just want to also call out that that total cost of care reduction, well, that's really exciting, and that's something that we always want to work with our customers to achieve. That takes a much longer time to actually show up in the data. So if you launch a program today, you're not going to see that show up in your claims data in 3 months, right? And so we always work with our customers to understand what are more near-term ROI examples that we can prove out that kind of show that we're on the right track to being able to achieve that. So you'll see a couple of different categories here. So cost savings, we've already talked about that. Then we have efficiency, which is definitely comes into play when we're talking about provider burden. So how can we create more efficiencies, prove out that we're creating more efficiencies to improve social care navigation, maximize provider system efficiency, and improving the value of care that's being delivered to be able to reduce that provider burden. Quality, how are we ensuring that we're enhancing the quality of services, the access to services, whether that's proving through increased HEDIS scores or being able to comply with quality standards that are set by groups like NCQA. And then separately, but equally as important, satisfaction. So how are patients perceiving their care? How are providers perceiving the care that they're providing? On the health payer side, are they retaining members, or are they increasing their membership? So again, all of these kind of make up ROI as a whole. And so we always want to understand really specifically what are we looking to achieve so that we can put in the appropriate interventions in place to be able to achieve those outcomes. So let's double click on efficiency. So if we go to the next slide, I think for the technology sector specifically, I think we have obviously a huge role in being able to support providers in reducing their burden, being able to gain those efficiencies. That's especially why we're invested in doing these evaluations with our customers and ensuring that we're getting feedback back to our product team. So we're always making enhancements to be able to achieve more efficiencies. So here are 3 specific examples with various customers. And again, after I am finished with this slide, I'll pass it over to Rachel, who will talk more about the how and what types of things go into this to being able to support our users being able to achieve these efficiencies. So this first one, I think this actually came out either this week or last week. It was made public, but we have a local government customer who's leveraging Unite Us to screen, refer, and reimburse for eligible services for their constituents. That helps working families navigate the benefits cliff as they increase their wages and move towards self-sufficiency. So here we saw 591 administrative hours gained and up to 3 million in savings in year 1 for the local government. Moving along for our health system customer who's leveraging Unite Us to coordinate the discharge process on behalf of their patients. Here we saw up to $8,000 per case manager in cost savings for 4 hours per week saved. And then last but not least, we conducted a cross-sectional survey of over 1,000 end users, which represented community, health plans, providers, and government to determine the relationship between platform usage and reduced feelings of provider burden. So this was a self-reported questionnaire, and we've had statistically significant results that showed highly active users were 2 times as likely to report reduced feelings of burnout. So again, just some high-level examples, but I will pass it over to Rachel to talk more about the how.
Hi, everyone. My name's Rachel Eager. I am a technical program manager at Unite Us, and I want to talk about a few of the items that Unite Us does offer in both in our platform and outside our platform that reduces provider burden. And I will weave in the topic of national standards and gravity standards throughout these items because that's a very important piece of what we're aligning to. So um, starting with interoperability integration, this allows our system to work within another system through a smart app, HL7 integration, or APIs. Ultimately, this helps to reduce provider clicks and means that we don't have to, a provider doesn't have to open up another browser to see social care history. And national standards are a huge piece of this to allow for those interoperability components to come together. The second thing Unitas does is allow for closed loop referrals. And our service lines directly align with Gravity standards to create closed loop referrals for pathways within our system. And this means that providers are able to see not only that they are sending a referral out for an individual, but what is happening with that individual as they are getting care from CBO or some other organization, meaning they're also not going to duplicate any of those services for that individual, causing them having to do more work in their system. On the next point, automated claims do happen within the Unite Us platform. And this means that a provider doesn't have to go outside their system to have to put in that claim and utilize another system and have more clicks overall. Something we are actually working with the Gravity project right now is to ensure that we're able to figure out some national standards for claims. And then finally, why we are all here overall, we're addressing non-clinical needs. And we know that addressing social care overall helps to reduce provider burden through enabling better outcomes for an individual themselves. But it also lowers hospitalization and lowers health system costs overall, to Emily's point earlier. Next slide, please. So I also want to talk about patients and the overall impact that Unite Us has on patients, because that's why we're here. We're really want to also focus on the holistic care an individual will get. So this leads me to how reducing provider burden also ultimately provides that holistic care for an individual. So here on the slide, you'll see 3 points. The first, when we have analyzed Unite Us, it actually reduces the readmission of new moms at month 3, 6, and 12, which shows that an individual is also getting better care from the Unite Us system itself. In addition, we have found that Unite actually creates a 63% reduction in unhealthy days for an individual in one of our pilots. So this also means that an individual is spending less time in the healthcare system themselves. And finally, just bringing it back and wrapping it up to the provider side, we did find also reduces the number of hours a case manager may spend each week, back to Emily's point around efficiency. So this again is really important because this means that a case manager may get to spend more time with their patients actually providing that hands-on care rather than doing paperwork. Next slide. And finally, I'd be remiss without actually talking about data standardization and what Unite Us does align to, because again, that's why we're all here at the Gravity Project having these conversations. So Unite Us does support and align with USCDI, which obviously we know Gravity Project does too, and that's really what's important here, creating those national standards. We also align with other interoperability standards such as HL7v2, FHIR, and then finally standard claims components such as AS6, ASCs. And then finally, we, as I mentioned earlier, specifically have a lot of API work going on, and we are utilizing these national standards for robust social care analysis overall. So I'm going to wrap up the presentation with those few points because it's important to bring it back to how we are not only reducing provider burden, but aligning with these national standards and continuing to do so. So I will pass it back over to Demry. Thank you all.
Awesome. Thank you so much, Rachel and Emily. Really appreciate the presentation. That was a great overview. I thought a few questions in the chat here. Whoop. Okay. Oh, looks like Emily answered that one. Okay. And then Lucy Johns had a question, reductions in use, who is the source? Was it a third-party evaluation or peer-reviewed somewhere?
Yes, I am trying to respond as quickly as I can in the chat.
Sorry, I just saw that.
I just shared one that was most recently published. So we leverage both our in-house research and evaluation team that will do these evaluations with our customers, but also work with third-party evaluations. So I'm trying to respond in the chat. It's not an easy answer. It's all kind of all of the above. So I will continue to try to respond in the chat.
Thank you. And then it looks like Christopher Hazen asked to provide additional details regarding EHR integrations,
Yeah.
like Epic.
I was actually writing back to
Perfect.
Christopher. We do integrate with a variety of different electronic health records, and our integrations may look different depending on the vendor itself, but we do have a smart app with many. And Christopher, if there's a specific vendor you're looking for instance, we integrate with Epic, Oracle, Meditech, Athena, some other ones, so I'm happy to provide more details on any specific vendors.
So maybe I'll just a quick follow-up, Rachel, thank you. I'm working in a county that has lots of EHRs. Unite Us is already here, but I'm trying to sort of navigate through community-wide discussions about what's next for Unite Us. And this is one of it has coming across as one of the blockers that, people see integration with Epic as expensive. And that's a barrier. And then a lot of people aren't running Epic. And so they're like, well, so what does that mean for us? So I can't give you an answer on what we're looking to integrate with. Our community needs to know what's possible and frankly, probably what's on your roadmap as well.
For sure. Well, I'm happy to take this back, Christopher.
Sure.
If you want to provide me an email and I can follow up in some way, so that I know what's in your community and we're able to give you better answers on that.
Okay.
See, Lucy's hand is up. You want to come off mute?
Yes, thank you. I put in the chat that some on this call are interested in the technical specs for your interoperability capabilities. Is there a link for all this? So responding person by person seems inconsistent with the purpose of this call, which is to inform a community about how you do things. So if there's such a link, or if you could produce that eventually, that would be great. Thank you.
Yeah, absolutely, Lucy. We should have a link somewhere, and if not, that can be something that we send out afterwards.
Yeah, for sure.
All right. Looks like Art had a question. How does Unitas uniquely identify community resources, and how might that integrate with standardized community resource directories outside of Unitas enabled healthcare environments?
Rachel, do you want to take that one?
Yeah, so I know we definitely are utilizing community directories and in many different ways. I think I might have to take this back a little bit and get you a little bit more information after the call, Art, to just make sure that I am able to point you in the right direction of the different community resources we are using.
Great. Sounds good. And I will be sure in the follow-up email, I'll put Rachel and Emily's contact information as well. So if you have direct questions or if anything popped up after the call, feel free to reach out to them directly. And then Carrie said, I assume that Unitas is a certified platform.
Oh, I mean, yes, but certified in what, Carrie, specifically? We're high trust certified. We're HIPAA compliant. We can throw in all of our other kind of credentials if that would be helpful.
Yes, that would be helpful. Again, the
Okay.
technical specs going on here. Thank
Yeah,
you.
of course. Thank you.
And I see one from Corey that just came in. Might be a little bit of a hard question he prefaced with, but can you speak a little bit about how using standards does or does not impact the value that you are able to deliver? For example, does the time savings case managers are realizing a function of standards-based data exchange?
Well, I think largely to Corey's point, interoperability is a huge component of some of the work that we are doing, and having standards that align with the healthcare system is very important for us to be able to do that interoperable work and make systems work together, which is a huge point of what Gravity is trying to do, align with healthcare and the components already going on there. So, to Corey's point, that does save a lot of provider time because of the fact that we are able to provide those integrations.
Awesome. And Sarah, I see your hand is up. If you want to come off mute.
Yeah, so I'm sorry I was a little late to this meeting because I was on a Colorado State maternal bundle thing. So this is very helpful because a lot of people were bringing up social determinants of health screening as one of the incentive metrics. But I was wondering, and this may not be part of the talk, but if you're doing any research around the cost benefit analysis of paying for your product, or I mean a platform in general, because obviously there's a fee associated with that, and again the benefit of screening and then the referral, so the new codes that are involved, because I think that would be one of the bigger things to get primary care involved. It's a very I qualified from my provider side as like one of the people who can participate without having to necessarily pay a large fee. But I think it'd be important for rural health care and obviously underserved regions. They're going to utilize your platform more, but trying to, again, prove that value through the new codes so that we can get them the I guess medical business justification to have a platform, because I think that's the biggest complaint from providers and their staff is that there's not an easy way to coordinate. And I've used Unitas and other platforms, and it's much more useful. And again, the efficiency and being able to actually care for more patients with their social determinants of health than without. So just, I don't know if you've already started that.
Yeah, great question. Honestly, it's possible. I'll follow up with my research and evaluation team to understand if we have anything that's active. But if not, I think we absolutely should. So I would love to kind of follow up with you on that.
Thanks, Emily. All right. And then Carrie just followed up with her question if Unitas is ONC certified or on the certified health IT product list.
Yes, I am actively looking that up and I will respond once I have the answer.
Perfect. Thank you. All right. Any other questions before we turn it over to the Together Now team? And feel free to, we'll have another Q&A at the end of the Together Now presentation, and then just make sure that we'll wrap up any last minute questions before we go to the implementer office hours as well. So if questions come to you, we'll save them towards the end and then make sure everyone's questions gets answered before we totally pivot. But now I will turn it over to the Together Now team. Laura, and I believe one of her colleagues is on as well. I've lost
Yep.
the name. Sarah? Perfect.
Great. So really excited to be here today. We're going to switch directions a little bit. Together Now is actually a community information exchange located in Rochester, New York. So we are not a technology company, though we have designed and implemented with community a closed loop referral system. So I want to talk a little bit about what it means to do that, to design with communities in order to reduce patient burden, and how we think about the gravity standards as part of that space. Next slide, please. So I think the first thing to begin to think about when you think about patient burden or community member burden is what an individual is really being asked to do, particularly when they have a health or social need. And what they're really being asked to do is navigate a system of services. And it's a system that was never organized as a system. It's a system that is really a collection of government and philanthropic, that was really created through a collection of government and philanthropic funding. It's not rational. In our community, it has over 3,000 services within it. So if you go to the next slide, when we really began our work in 2017, what we said was, how can we integrate this system so that we can begin to create solutions that are really beginning to target overwhelmed community members, siloed sectors, disconnected providers, and poor outcomes. And I will say, for our purposes, that siloed sectors was really important. We began our work under what was called the Monroe County Systems Integration Project. And in that case, we were really seeking to create an integrated care system that really bridged health, human service, education, and public sector. So for example, we have community schools as core pieces of our provider network. Next slide, please. I wanted to highlight our collective vision that, again, we really put in place in 2017 to demonstrate why our focus on the person was so important. So we said we wanted to work across a diverse network of providers to build this interconnected person-centered system that stretched across health, human service, education. We wanted to leverage a unified information platform, and our goal was to improve both health and economic well-being with a particular focus on those who are vulnerable or impacted by poverty. And I just want to highlight that notion of person-centeredness, because that we really took that as a verb, and in all of our work as we designed both the workflows that we wanted to enable as well as the technology that we wanted to facilitate those workflows, person-centeredness was a core business requirement that we maintained. Next slide, please. So some considerations as we begin to think about, like, what did it mean to deliver person-centered solutions? We did a lot of talking with community. And one of the things we found out very early on was that community members really felt commodified by traditional referral workflows. So community members knew that oftentimes they would enter an organization for one need, be screened and referred to another organization for another need, and that there was a financial transaction tied to that interaction. And because of that, they felt less confident that their actual wants were being taken into consideration. And instead, the two providers, the referee and the receiver of the referral, were passing them amongst each other to earn dollars. We also really heard from community that they knew their needs best and they wanted to be part of this interaction and this set of transaction. In our community, we really recognize that in order to adopt and to ensure adoption, both across providers and across community members, our data system is unique in that it does have an individual community member component and that self-referral is possible. And so in order to do that, we really had to create a journey of trust. That journey of trust is with the individual community member through our consent process. It's with our providers in our network as they move from community-based front doors to network providers. So much of this work, it's not about just, again, sending referrals through technology, but it's about building trust towards a more integrated, coordinated system. And through that, you're building individual agency and meeting individual needs, which is really what it, creating hope among community members. When you talk about reducing patient burden, reducing community member burden, much of that burden is about being shuffled through a system, not really knowing how your needs are being met, often in crisis and often at the expense of the outcome we're all seeking to attain. In order to meet these needs, we really use tools of human-centered design to fuel community-centered technology solutions, which in turn enable both usability and adoption in our community. Next slide, please. And wanted to sort of tie this together with some of the work I've done previously with Gravity. I was lucky enough to be able to participate in the Gravity Social Care Co-Design project with both Civitas and Gravity as sponsors. And within this, we had a lot of community-based organizations and community members talking about the role of community members in this body of work. We really discussed that it was so important that an intervention referral also empowered individuals to navigate themselves when appropriate. So we heard a lot from community members, like, I don't need a navigator every time. If given the right information and the right tools, I should be able to navigate myself and have better control over how I move through the system. And so a lot of our design work and our implementation work has been in order to enable that. Next slide, please. Some of the impacts of having a person-centered perspective on the closed loop referral standard, which you don't see today, but hopefully we will see in the future. If you're having a person-centered perspective and seeking to reduce patient burden or community member burden, one of the first things you need to really begin thinking about is that it's not a patient, it's a community member. And how do you begin to shift that language? In the current closed loop referral standard, the patient is the subject of the referral, but in a person-centered system, the community member is actually the enabler of the referral. In the current standard, the provider is the enabler, but in our system, in a person-centered perspective, the provider is invited to an individual's care team. Similarly, the CBO is the receiver of the referral, but in our system, again, the CBO is invited to the care team. So you really have this shifting role and responsibility, and in doing that, you are empowering individuals and therefore reducing community member burden. Next slide, please. And so again, our work began in 2017. We really went through a process of gathering business requirements from community members, from service providers, health, human service, education, and really sought technology that was going to support us in creating this very person-centered system view of how we wanted to work differently in our community. We actually ended up working with IBM as our technology partner to build a tool called My Wayfinder. And My Wayfinder is unique in that it is really about centering people in the care system and empowering those who deliver and receive services to work together. And so maybe the final thing, next slide, please. The final thing I would add is from the very beginning in gathering business requirements all the way through implementation, and even today as we do user group meetings like on a regular basis, we're really continuing to design with community. What this means is we have a community voices network who meets on a regular basis and not only provides input to us, but also is our champions within our community. We actually have an equity review board who looks at both workflows as well as key pieces of our product design to say, is it accessible to community members. So for example, in our community, we have a large deaf population. And so really worked with our equity review board to ensure that we were putting videos translated into ASL into our system at appropriate places, such as helping people understand informed consent. So it was better ensuring accessibility to the body of work. Again, really use human-centered design throughout. Some of our results in this space, Designing with Community, we've engaged over 15,000 community members. We've trained over 400 human-centered design practitioners. This includes both community members and service providers. We have strong KPIs for inclusion that were really important that we both met and publicly reported. Over 80% of our deliverables have been reviewed for equity and impact. And our measurement model powers the analysis of system inequity. So when we just talked about the ROI of implementing the system, that's exactly what we began to look like. What is the ROI and the active integration? Because it's truly the active integration that these technology solutions are enabling. Next slide. So with that, I'm going to turn it over to Sarah, and Sarah is going to talk a bit more about how we have built trust with community and then how that shows up in My Wayfinder as a product.
Thank you, Laura, and good afternoon, everyone. I'm Sarah Voles-Rogers. I'm the Director of Network and Community Engagement with Together Now. I'm super excited to kind of share the how and all the goodness that Laura spoke about. So when you think about reducing patient burden, part of that is to really understand what that looks like from the community perspective or the end user. And in order to do this, we understood we had to go through a journey of trust with community. And what you see here is from the community social capital model out of the University of Minnesota. And really just high level, what this means is at the center is community, right? That efficacy is really the belief that community should be center, belief that community can make a difference and want to be part of the process and owning their journey. That inner ring that you see there is the trust building, and that's building trust with each other, building trust with organizations and systems, especially from individuals who haven't always had the most positive experiences within systems and at times have identified being harmed by systems. So there's really a journey that needs to happen to really think about how are we building trust with organizations and systems that exist in our community. And then that outer ring is the engagement, right? Like really building that bridge within community, within neighborhoods, across systems, and that really organizations and these systems are bringing resources that really provide change for folks, and that individuals really have a sense of belonging as part of this process. Next slide, please. Some of the methods and kind of which we use to really engage community and kind of partner and go through this journey of trust. We've used the IAP2 spectrum, which I'll dive into a little bit in a future slide. Laura talked about really that human-centered design and really being at the core and the center of our work and how important that co-design is to help really develop the person-centered solutions that we offer, including My Wayfinder. And then Laura mentioned also those community champions, those liaisons, those trusted messengers who really know and understand community, understand the strengths, but also can help identify challenges and gaps and be thought partners and solution in partnership with us. Next slide, please. What you see here is the spectrum of engagement. So this was really a useful tool for us as we looked at how we navigate in community and partner with community. This is the International Association for Public Participation model. And really this helped us as we looked at how we plan, how we communicate, what our expectations are for participants in our planning and decision-making processes. But also as part of our work, we truly believe that those affected by decisions should have the right to be part of the decision-making process. And in order to do that, we really go through this journey with them and empower people to be active participants in their overall health and well-being. Next slide, please. Some ways in which we did that. Really some empathy interviewing where we're gathering residents' experience, which really informs our practice and our service pathways and individuals being connected to resources in a way that makes sense for them. We held tons of focus groups and workshops, really allowing residents to weigh in solution and really have a seat at the table, right? To really inform every process that we had gone through as we developed and created and even iterated several times the work that we've done in community. Laura spoke about it, these advisory boards and these regular meetings and consistently having community feedback, doing these public events and forums to really make sure that we kept community at the center. As you think about how you're going to alleviate that burden, needs to also come from community. Next slide. We developed a collaborative governance model. We have shared power in our policies and practices under ERB, in which Laura spoke of. We also have a community voices network, which is community driven, right? Where they're able to provide input and solution with us. And when you're thinking about how you're engaging in community, there really is a difference between engagement and just wanting and understanding feedback, but even furthermore, collaborating with community and making them part of the decision-making process. Next slide. So Laura talked about this, so my Wayfinder. So part of what we do in community and how we leverage partnerships and the development of my Wayfinder and this tool is to really support community and thriving. And again, putting individuals at the center of that. And when you're thinking of the referral process and connecting to resources, it's really driven by the individual as part of our network. Next slide. So what is my Wayfinder? So my Wayfinder is a closed loop referral management tool, and it really helps individuals and community not only navigate available resources, but also connect with providers they want to work with across health, education, and human services. Our tool is free for individuals to use. It has capabilities for individuals to search and connect to resources anonymously, which is what community kind of lifted early on, reducing the barrier to actually increase or get access to supports and services. We understood from either experience and community, like it can't be that individuals have to cross all of these hurdles and obstacles and share all of their personal information with every organization they come in contact with to either not qualify for the supports or services or be turned away. So that anonymous use allows individuals to have transparency for the resources that are available in our community, but also to ensure they qualify, right? To be able to have those conversations and connect with providers they want to work with. It is free and it's secure and confidential. Next slide, please. So what are the user benefits of leveraging my Wayfinder to connect with providers and resources? Individuals are able to search and track services all in one place. So when you think about integration, health, education, human service in one spot really gives community members a wealth of resources they can connect with specific to their needs in addressing social determinants of health. It is a secure and safe way to share information with providers in real time. One of the things that community members had lifted early on was repeating their story over and over and over and over again every time they connected with a provider, right? That's not necessarily the best way to have individuals connect, but also it doesn't serve community to have to repeat that information over. So through my Wayfinder, they're able to securely save that information all in one spot. And through consent, organizations that they want to work with have access to that information. Community members lead in my Wayfinder, so they're really at the center of that. Consent lives with the user, so they're able to invite providers they want to work with to connect with them and be part of their care team. To add consent is easy, and also to revoke consent is easy for the user, but it is really a way for them to take a lead on their overall health and wellness journey and build those care teams around the things that they really need, want, and be able to champion that in partnership with organizations. The user is also able to give feedback directly to the organization once a referral has been completed in the system, so that the organization is also able to see what that user experience was. They could capture that information and also use that to inform future practices, policies, and procedures as well. Next slide. So when you think about an individual's kind of like wholeness journey or wellness journey, these are some of the benefits that a user has in My Wayfinder. And again, being able to take the lead in their wellness journey. They're able to take screenings or check-ins where they're asked questions around food, transportation, housing, dependent care. And the user is really then able to self-identify need on a scale from not okay all the way to excellent, to be able to then capture what are priority for them and what services they'd like to connect to. From there, based on their screen or check-in, My Wayfinder then curates a recommendation list based on how the individual identifies. So if they identify needing food as a priority for them, the system that will then populate food recommendations as a starting point for that user to be connected. So when you heard Laura talk about individuals want autonomy to navigate resources, they can do so through My Wayfinder, and a check-in is one way to do that. Then they're able to also connect directly to providers they want to work with. So the referral process in My Wayfinder can go from the person to provider they want to work with, and then one consent is given from provider to provider on a person's behalf. So you really do get that full closed loop referral through the tool. Next slide. So what does success look like for our community? Like really, what are the end goals? And when you think about how we center community, how we partner with community, giving community a seat at the table, really thinking about how they're connecting with services and partnering with our local organizations, we really want individuals and families to be empowered, right? To have this tool to advocate for their overall health and well-being. Information through this tool and through our network are shared thoughtfully and with intention. And folks have confidential access to resources. We then as a community and as a network are able to identify community trends to help shape how services are delivered in our community. We're able to align and coordinate efforts across sector with the person at the center of that, and then also being able to invest in how money is spent, right? And how time and energy and effort is poured into our community and meeting community need. Next slide. This is just a depiction of kind of like, how does that look like in action, right? So as you think about engagement and really centering community and how you engage with end users or patients, this really kind of gives you a cool snapshot of what did that look like for us in the beginning when we launched My Wayfinder in community. And then in 2023, we kind of did this boots on the ground engagement, putting My Wayfinder in the hands of people. And you see the growth and utilization of our referral management and connecting with providers across our network. So it's just a really cool depiction around people really want to have tools and resources, and they really want to take a leading role in their overall health and well-being, and they're able to do that by leading through the leveraging My Wayfinder. Next slide. So just a really quick snapshot, one of our partners in community is the City of Rochester. We work closely with the director of the Office of Violence Prevention, and they actually have a street outreach program that we brought on to educate them and to have their staff leverage My Wayfinder. And some of the feedback they got and how they're able to support community is they're really getting on-spot connection. They're able to reduce, especially for individuals who need housing and food and transportation and crisis support, really being able to do that direct connection. And because that closed loop referral is there, the user also participates and can see the outcome, right, and contributes to that. So they're able to, in real time, as they're engaging community out in the streets, provide this support and service to community members in real time, leveraging My Wayfinder. Next slide. We've also worked with the Adult Workforce Development program with the City of Rochester as well, and they're really focused on that human-centered design and really being able to look at job retention across 10 organizations. And what they're saying is these organizations are working with community members in real time to really look at what other resources are needed for individuals to maintain employment, right? So those transportation needs, those childcare needs, really, how do we leverage that and make those direct connections in supporting individuals' job retention as well? Next slide. Now pass back to Laura.
Yeah, thanks. So a couple of things I would just highlight, and then I see some questions in the chat. The first one I would say is because we built a custom technology solution, and we really wanted to wait until we did full public launch. And so we went live with My Wayfinder 3 years ago. And for the last 3 years, we've really, again, been conducting that journey of trust with both our provider network and community. What that means is we have a public launch booked for a couple of months from now, but we, have made good progress even before that. So these numbers are all pre-public launch, and so we're pretty proud that this is all through relationship and through getting word out in community and word of mouth. But from there, what our network looks like, we have 8 navigation centers, over 70 contracted partners, connected services, over 650 trained users using My Wayfinder. My Wayfinder is a tool. It's really interesting. So to step back, because this I think is somewhat related, how we leverage a community resource directory in My Wayfinder is we use our local 211 community resource directory. We really see our 211 community resource directory as a public asset and have really sort of changed the culture in our community to embrace that and to have collective ownership of that database. And so we like to say a person can call, click, or come in for help. That means they can call 211, they can click on My Wayfinder, or they can come into a navigation center and have a common access to the service delivery system. And so I want to just highlight what that means is even without public launch in our community, we have over 25,000 unique users using My Wayfinder. These are service providers searching for services and connecting services. These are individuals. You can see My Wayfinder has been used to find services over 150,000 times, over 45,000 sessions. So excited to see this growth and really excited to see what happens as we public launch in the next several weeks. And from a community side, we are out on the street. So we're engaged, constantly talking to community members. We're at community events. We're, again, trying to build that in order to reduce the burden on the community member, you have to give them tools and tools that they trust. And so that is a boots on the ground activity in our community. And we are out there doing it. I think the great thing is when we ask community members, are they likely or very likely to recommend My Wayfinder to a friend, over 95% say yes. So we feel like we have begun to realize what we needed to. So that's sort of so much more. I really wanted to focus specifically on the topic of community in My Wayfinder and how we're engaging them in the build. I would highlight what Sarah said. We are participating in Gravity. We have adopted, IBM's our technology partner. The data fabric My Wayfinder built on, has adopted all the FHIR HL7 standards. There was a question in the chat about how we are working with, how are we sharing data with clinicians? So I would say a couple of ways. The first thing that happened in our community is our 2 health systems are both Epic users in our community. And they said, and this was several years ago, they said to us, our clinicians aren't ready to make a closed loop referral, but we want to get them start practicing. And so they began screening, and then we facilitated an integration directly with Epic so that the 211 community resource directory actually flows from My Wayfinder into Epic. That was like the starting point. And so what happened as sort of phase 1 is that providers were doing a screening and then using that service directory to put referrals to services in the after visit summary. We then began working with our local health information exchange to say, how do we begin to do community-wide? The next thing we focused on was like community-wide referral. So we really saw that the HIE was the core mechanism by which we were going to share this information through a single set of pipes with the healthcare community. And we've been working with our HIE to build pieces of that integration over the last several years. Some of that is to, for example, support our current 1115 waiver implementation. Another body of work, we actually worked on leveraging the Rio to begin to say what might it look like to exchange referral information with the HIE as the center between My Wayfinder and Unite Us. So that has been successful. So that's sort of, I would say that's right now, we leverage we work with the health systems and leverage the HIE to say, what data do you need? And how do we leverage the same type of the same set of pipes to have a more integrated approach to data transfer? And that's been pretty successful. Is My Wayfinder an IBM product or service? So I will say one exciting thing that happened over the past 6 months also is IBM has taken My Wayfinder and turned it into a software as a service solution that's now available to other communities. I think part of the reason they went in that direction is that we find that other communities, particularly those focused on community information exchange, are seeking person-centered solutions and seeking solutions that cross multiple sectors and not just health and human services. And so we've had several requests for, can we procure My Wayfinder? What might that mean and look like? And so, yes. And then Sarah said, do you want to speak to the Connect-a-thon to me? So I will say yes. We were excited to participate in the previous IBM Connect-a-thon to really, I think one of the reasons we are really enjoying our participation in Gravity is that, the folks at Civitas and Gravity have been really open to think about the patient experience outside of the clinical setting or outside of the CBO setting, and what might it mean for an individual to interact with these technologies from their home or from in other spaces. I think you saw at the original slide of like what's happening with Gravity coming up is they're going to start exploring, for example, in the technology work group, the self-referral use case. And we've looked at some of those use cases from a Connect-a-thon perspective to say, if you're developing these standards, like we want to be part of testing them. We want to make sure the workflow is like what needs to be enabled in community. And I think that's part of what's really exciting about Gravity is we have the opportunity to sort of sit in these spaces where policy and standards are being made. We're in the systems change business. For us, systems change is often acts of integration, and participating in Gravity is part of that, really being part of setting these standards. So. Are there other questions?
Yeah, any other questions for Laura or Sarah and the Together Now team in the chat? See Sarah DeSilvia, I'll clarify, we got two different Sarahs on, posted the link to the Confluence page with the Gravity SUH track. So that was helpful. Thank you, Sarah. Awesome. Okay. Great. So if there's no further questions at the moment, happy to transition over to the community office hours. So if you weren't able to join us in February, this is our time as part of the standing agenda for our meetings, where anyone can just pop in and ask general implementation questions for the Gravity team to answer. So anything that's come up in your part of implementation or just any general questions that you've had, terminology, technical, etc., implementation, feel free to ask here. So also this is an open forum.
I have a question for the My Wayfinder team. I was struggling to get off mute on my phone.
Oh, good.
I guess what are your next kind of technology priorities or expanding the, new functionality or new challenges? Did you say that you are able to exchange referrals with Unite Us through Rochester Rio? That's happening right now, or
Yep.
more in the process?
We're doing a full community-based referral process. So it will be, the goal is to leverage the gravity standard to exchange referrals among any closed-loop referral platform. We started the work with Unite Us. We also find help in our community. So part of it is really saying, regardless of the originator, like how do we create, we also, for example, our Office of the Aging has a referral system, particularly for just aging services. So, you know, it's how do you take that expanded view, because the individual isn't served by having 4 referral networks managing different referral sets. And so again, for us, it's always how do we integrate to create that person-centered experience. Some other things we're working on, we've been working with New York State on really looking at the SCN workflow, social care network workflow under the 1115 waiver, and saying, how do you create an independent module within my Wayfinder that enables very specific healthcare standard for a specific program, while also ensuring my Wayfinder can maintain functionality and community focus. So that's something we're digging into. With IBM, we're really looking at the impact of AI and how you can deploy AI in this type of work and in this type of system in a way that is also person-centered, and in a way that also contemplates this journey of trust that has been so important to get us to this moment in time. I think like it's interesting, the environment continues to change so rapidly. So I think beyond that, you know, one of the things we're really seeing just locally a lot of progress in is our work in supporting education. So like outside of health and human service, I will just say, for example, one of the things we're really focused on is we have a cohort of community schools. We have a cohort of universities. We have, you know, really looking, we have a cohort of workforce development providers and trainers. And so really for us, it's about what are those core workflows that community wants integration on, and how do we rapidly deploy, you know, technology solutions under a single product line that's going to create like integration and smooth transitions across sectors. Like that's our overall body. And I think because we've really taken a module approach with My Wayfinder, we're able to do that pretty rapidly. I don't know if that answered your question.
It totally does. You're very exciting work you're doing. Very exciting. Anything around, are you doing anything around like improving enrollment and like government benefits, like eligibility, forms, that kind of thing?
It's a really good question. So I'll say we've had like jumps and starts, I will say, in this. So the first thing I would say is we provide project management support to a benefits calculator that we've been working on forever with a partner organization, with the goal originally of integration, and maybe we'll still get there. You know, certainly we want to have that type of benefits calculator integrated into My Wayfinder. But I think we also, so I'll just give an example. During COVID, we staffed a project and a body of work focused on eviction prevention. And the first thing we did when we started that work was map out the existing process to prevent evictions in our community. And what we found is that we found that the process was broken. You know, based on 20 years of like not true policy, but just CBO procedures. So the process in our community is that an individual had to go to DHS, get a denial, and then shop that denial to CBOs across our community until they found one that could maybe serve them while they're facing eviction. So we transformed that process and like created a single point of entry into the system. We you know, worked on benefits management, and to your exact question, like how do you have forms that move with a person? How does a person have a digital wallet that's holding their core information? And by refining that workflow and leveraging technology at key points within it, we were able to prevent 10,000 evictions in a matter of months. So, you know, we always see technology as the enabler, but it's not the end point of the enabler. You know, it's not the end game. It's when we deploy it when it needs to be deployed to deliver the solutions we need to deliver. I don't know. So certainly like lots of work to do in that space. And
That's really
And
exciting.
have had some good success so far. Yeah.
Really, I'm was struggling on my phone and was looking for the applause icon. Instead, I put up my hand. So congratulations on that work and yeah, great, great work.
Thanks. I mean, another example is we brought DHS into community school space because community schools were actually serving families in the school setting. And yet there was this huge gap between the district and DHS. And so how do you enable those interactions on site? And how do you leverage technology to do that in a secure way? So again, it's explore. I think for me, it's always how do you reduce patient burden? You take it upon yourself as like the system integrator to explore the overall process and then design with community and apply workflow redesign and technology solutions like at the right moment in time.
And I see Robert had another question in the chat. He asked if the capabilities that you're describing are just limited to Rochester. He sees that he can sign up in Colorado, but is there service integration in Colorado?
So right now, my Wayfinder is, deployed. Together Now is in Rochester and is deployed in, Monroe County and contiguous counties. Certainly, there's other. So right now, yes, it's limited. I mean, we do consulting services in other spaces, but our work on creating an integrated service delivery system is really focused on Monroe County and contiguous counties in New York State.
Thank you. Okay, any other questions for Laura and Sarah and team? This has been a great conversation. I've learned a lot. So I'm very appreciative of the Together Now team and the Unitas team. Or, oh, go ahead.
I was going to say, I wrote this in the chat, but just thank you. I know this topic was, I must admit, I kind of forced this one, Deborah.
It's been awesome.
Because I know, because I saw the presentation at the UCSF Siren annual meeting on provider burden and ROI and closed loop referrals and gravity standards. And I knew about Laura and her work in self-referral and addressing patient burden and patient perspectives. And it just seems like in the grand scope of gravity, leaning into how our standards are actually contributing to return on investment, focusing on patient perspectives and provider perspectives and provider burden is so critical. So thank you so much for just, hitting it out of the park. It's all very well and good design standards, but they have to be used for the good. So the two of you coming here and, well, all of you, the two entities and all of you working and then voluntarily aligning with gravity standards is a wonderful thing. Thank you so much.
Thanks, Sarah.
Can I, this is Rob, so I will come off mute because I want to agree with Sarah and I want to point out something that not only agrees with what she said, but speaks to the little weedy technical things that I was actually asking about. Because a lot of the folks that are on this call are focused on the weedy HL7 technical things, but what Gravity does is provide standards, and I'm using that word meaningfully, that aren't necessarily tied to requiring that people do the deep technical fire exchange standard. It's about using vetted material and hopefully aligning with I'm a terminology guy, so concepts that are agreed upon within a community and hopefully integrating those in terms of the exchange that you provide in terms of doing that closed loop referral and things like that. So I just want to, I congratulate both of the organizations. They're working hard in an area that's tough, that has a lot of technology barriers, and just making sure that you use the things that Gravity has, worked through and confirmed are valuable. And again, hopefully using standardized terminology, even if you're not sending it using fire stuff, is great stuff. So I encourage, you to continue to do that and congratulate you on the work that you're both doing.
Just know, I want to thank you both. And I would say, like, when we started this work, and I'm sure Unite Us folks feel the same, like, being out there on your own feels really scary. So I think for us, we really appreciate Gravity as, as a partner and as a set of guardrails and as a set of inspiration, and that we can have a conversation. Like all of those things are so important, and it's much better to do this together. And I just appreciate that Gravity is willing to do it together. This is not like, I love Sarah. It's not a top-down approach. Like we are walking together and figuring it out, and much rather do that than trying to figure it out on your own, which is so scary and all of us are still together at that like front end of innovation, like right on the precipice. And so it's great to be there as a group versus like solo.
I would definitely echo that. And I probably can't say it as well as you just did, Laura, but yes, 100% agree. And I just appreciate all of the partnership. And I think there's also just so much momentum in this space and this like going in so many different directions. Like we talk a lot about the payment and reporting exchange pieces, and that I just appreciate all of your leadership in supporting us to be able to further those standards so that the work can continue.
Yeah, and I think just coming up to echo what Emily said, the work on social care capacity and some of these things where it's just so important that we continue to have these conversations on alignment, not only for interoperability, but to ensure that we are able to do the right analytics across social care. So very much appreciate everything.
Definitely. And I like what Jonathan put in the chat. Slow progress is better than no progress. So I echo that. Awesome. All right, we're in the last 9 minutes. Does anyone have any last minute questions for anyone? Unite Us Together Now, just general open implementer questions. I'm happy to give people 8 minutes back if they need.
I have a kind of technical question.
Yeah, go ahead.
I was just wondering, this could be for anybody really, like when organizations have like billing codes, right? Like CPT codes, for example, and then you also want to document like other codes that pertain to the intervention done in the billing code. I was just wondering how people represent that, like the relationship between intervention codes, right? That like this 60-minute segment of community health integration services is associated with, let's say, educating somebody about SNAP, and enrolling them in and da 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 da. Like, so the question is about the relationship between these codes, or if there's, or if that's even something that's maybe it's not important to document that this service was provided as part of that service.
I am going to state, Matt, that is a very large question.
Oh, okay. I didn't know that I did that.
There's a lot of really in like thoughtful modeling of reimbursement happening to support leveraging gravity standards to support the 1115 waiver in New York right now, which I think is worthy of a whole call maybe on its own. And also, I just want to note what Emily mentioned. We're kind of also on the cutting edge of supporting our members and gaps in standards for reimbursement. So I just note that of course the New York waiver has a pretty sophisticated model of what wraps around the simple information of service delivered in service capable of reimbursement. But that's maybe worthy of a whole call.
Yeah.
I mean,
So,
maybe.
Yeah, I would say, so just to simplify what I said, you have a time-based code, right? That could refer to, like community health integration, that could refer to any number of many, 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 many things, right? It could fall under it. And then you have more specific codes that are defining what happened in that time-based code. That's the
Oh yeah,
use
yeah.
case,
So
right?
yeah, so we did that. So that is actually, well, I think it was our April, Demery, hold me accountable. I think it was the April implementation affinity meeting of last year, did a crosswalk of all of the granular gravity labor and procedure codes and how they mapped intentionally by design to support the labor of community health integration in CHI aligned with the Medicare physician fee schedule. And that webinar is available in the resources for implementation section. It's as a webinar continuous resource.
Great.
And so that, yes, by
Thank you.
design, high level granular concepts, drilling down to the actual labor and activities of community health workers. And because one of the things we do at Gravity is really try to, from a labor justice perspective, is make labor visible too, the labor that it takes, like for community to connect individuals to services. So all that was in that meeting.
Thank you.
All the nerdiness of that is in there. And if that doesn't answer your questions, we're here to help.
I knew you'd come through for us, Sarah.
Okay. Okay. And again, if it's not April, it's March. It's like one of those, I think. And we can even put the link in here before I go. Hold on one second.
Wonderful. Thanks, Sarah. All right, and I see a question in the chat from Art. I was going to type it out, but I can just state it here. That yes, thank you for the reminder that we did discuss that, and we're really happy to go back to that. So Corinne and I will make a note of that, and maybe I know we're toying around with a couple presentations for August, but during maybe the open implementation section, we can revisit that because I think that would be really helpful. Thank you, Art. And Sarah just shared that YouTube link in the chat of the webinar that Matt and her were referring to. So thank you. All right.
I have to go to lead the terminology call.
Awesome. Yes, shameless plug. If you're available and have another hour, feel free to join.
It's a very procedural end of domain vote meeting, not the most exciting meeting, but we'll reconvene in August. And thank you all so much, and grateful always to be in community with all of you.
Yes, definitely. Thank you, Sarah, and thank you everyone for joining. Thank you so much to Unite Us and Together Now team. We're really grateful for the awesome presentation this afternoon. Saw a lot of great feedback in the chat, and I know I definitely learned a lot. So very grateful for their time. And like Sarah said, we will reconvene in August. So stay tuned. We'll be posting more information about the August meeting on our Confluence page. So that is where you can stay up to date on that. And we will be posting the meeting materials following this call in the next day or so. So thank you all so much for joining us, and to the Together Now and Unite Us teams. Thank you again. It's the end of the day for me, and apparently I can't talk anymore. So time to wrap up, but thank you all. Very appreciative of your time.